elaborate further on what the previous speakers did, which in fact is if water is a problem, fluid overload is a problem, then de-resuscitation may be the solution. These are my disclosures. I'm a member of the advisory board of Göttingen, and these are my other disclosures. As stated, I recently moved from Antwerp to Brussels. So we'll give a brief introduction and then tell you a little bit about the what are we talking about, why is this important, when should we think about de-resuscitation then, and how can we guide this final phase after initial treatment of our patient. So as the first speaker already alluded to, the first question is when to start giving fluids. Because the best fluid is probably the one that has not been given to the patient unnecessarily. Then comes the next question is, of course, when to stop giving fluids. And as some patients may need a little bit help, they may need active fluid removal or de-resuscitation. And of course, when we are taking fluids off the patient, we must by all means avoid hypoperfusion as well. So the question is, how do we guide this treatment? But first, what are we talking about? So fluid balance is the sum of the ins and the outs. Fluid overload is defined by a cutoff value of 10% increase in baseline body weight expressed as fluid accumulation. Early adequate goal-directed therapy, not going into detail, it's different definitions, but you could use the surviving sepsis guideline ones. Late conservative fluid management is 2 consecutive negative fluid balances within the first week of ICU stay. And late goal-directed fluid removal is the active removal of excess fluids, and this is what we refer to as de-resuscitation. So recently there has been an increased interest in these 4 phases of fluid therapy. Although at the same time 2 opinion papers came out and there is a bit of a discussion on the ideal acronym, but I must say that if you ask the social media, there is a clear preference for the ROSE acronym over the SOSD, which is a bit difficult to pronounce. And soon will be out a review elaborating on these concepts. So let me present to you the ROSE. So we have to save the patient and resuscitate. Then we have to support the organs and optimize hemodynamic condition. Then comes stabilization, going back to maintenance and homeostasis. And then at some point, most of the patients will evacuate the excess fluids themselves in a polyuric phase, but some may need a little help. So after the first hit, whether it's sepsis or trauma or burns, the patient enters a NAP phase, is hypovolemic, and fluids will stabilize. Fluid balance must be positive, and then we will stabilize neutral fluid balance, and then the patient enters the polyuric phase and will get rid of the excess fluids that has been given in the ER or in the OR, hence the ROSE acronym. But I must tell you, ladies and gentlemen, that with the blossoming of the rose, the last rose is just a dry rose and not a dead patient, of course. I'm really, really happy to see that this ROSE concept has been taken up, and others in other countries are now also looking at the 4 phases of fluid therapy. But if you look into the literature, most of the studies have focused on the stabilization phase, so not the really early resuscitation phase. A few studies there, and only few studies looked at de-resuscitation. So it is a bit of difficult at this point in time to tell you how exactly can we guide you through these different phases. Brings me back to the ebb and the flow phase of shock. So the ebb phase is when the patient is clammy and sweaty, is underfilled, and we will guide fluid resuscitation based on what we've learned in the previous lectures on functional hemodynamics, blood pressure, passive leg raising. But after this initial resuscitation, when the patient accumulates fluid, we need other markers. There may be organ function, like the F ratio, extravascular order, and why not intra-abdominal pressure? So it's about finding the balance and our way within these 4 phases. So after rescuing the patient with the goal-directed therapy comes the optimization, and then maybe the late conservative fluid management to stabilize the patient, and then the late goal-directed fluid removal to evacuate the excess of fluid. So it is these 4 phases and the different goals and the different targets that we may use, and this is the topic of my talk, because probably at the late phase when we are de-resuscitating, it's the impact of the fluid overload on end organ function that will trigger active fluid removal, of course at the end avoiding hypoperfusion and tissue hypoperfusion. So as I said, it's about finding the right targets in order to reach the right goals, which is to avoid fluid overload and global increased permeability syndrome. So why is all this important? Because I personally believe that peripheral edema is not only of cosmetic concern, it is a real threat to the patient. Because we've seen over and over again that fluid overload in sepsis, in AKI, in ARDS is related to poor outcome. I'm not going into detail, but the bottom line is that a positive fluid balance is an independent prognostic factor, unfavorable factor in patients with sepsis. And if you would aim for a restrictive treatment, you would improve outcome. The reason why all this is important is because fluid overload has an impact on end-organ function. So when there is congestion, and especially venous congestion in the kidneys, in the lungs, there will be organ injury and end-organ failure. So this may favor the idea of late conservative fluid therapy, or even a combination of early adequate, late conservative, or early conservative and late conservative. And as you can see in the few literature data available, the late conservative part maybe plays a more important role than the early aggressive one. So we should by all means avoid fluid accumulation. So then the next question is when? When should we think about doing something about fluid overload? It's exactly when your patient is not transgressing spontaneously from the ebb to the flow phase or the polyuric phase of shock. So let's summarize. When you have an event, it's the first hit. It's sepsis, it's trauma, it's burns, and there is a systemic inflammatory response, increased permeability, and the patient will accumulate fluid. And in fact, the amount of fluid accumulated is like a biomarker for critical illness. So most of the patients will reverse shock because you give the right antibiotics, it's a good surgeon, and you have a good source control. But many of our patients will remain in what I would say an unresolved state of shock with a global increased permeability syndrome, anasarcodema, and organ failure and dysfunction. So GIPS is, to my point of view, a positive cumulative fluid balance with new onset organ failure and dysfunction, which we could monitor by oxygenation, extravascular lung water, permeability, or maybe intra-abdominal pressure. So now, how should we do this at the bedside? Question is how to assess hypervolemia. And the other part of the question is how to monitor and guide the resuscitation. It's a very good book by Ronco and Bellomo, which talks about all the problems related to fluid overload and how you can monitor these patients. What I would like to do with you today is just give a brief overview of what are the possibilities or what are the potentials for the future. Of course, we start with clinical management. We can have biochemical or lab parameters. We can have imaging, could either be static, chest X-ray, or dynamic ultrasound. We could go for advanced hemodynamic monitoring, like we heard from previous talks, or focus on organ function or capillary leak within the end organs. And there may be other new promising techniques like bioelectrical impedance analysis or electrical impedance tomography. Because of time's sake, I cannot go into detail, but clinical parameters are not adequate enough to guide the resuscitation. And I'm afraid biochemical ones may not be ideal as well, and a static chest X-ray won't tell you everything either. So I just want to point out that POCUS, point of care ultrasound, is important. It is like the modern stethoscope in the ICU, and if you lose inferior vena cava collapsibility and have a low index of collapsibility, like in this patient, you may think that he is fluid overloaded or not fluid responsive. But in fact, I showed a video on the internet and asked at people what they think about it, and you see that people are confused because just an inferior vena cava doesn't do everything. This was a patient with cardiac tamponade and obstructive shock, in fact, who was hypovolemic with a dilated vena cava. Ultrasound of the lung and looking at B lines as Daniel Lichtenstein, and there are more than 10 good reasons to look at the lungs. Just one slide on biochemical parameters. as Xavier Monet and Jean-Louis de Boer looked at the effect of total protein levels and how they could be related to hemoconcentration or hemodilution. Or the chairman, Professor Burrell, published about iatrogenic hemodilution. So if you have hemodilution, this could also be an indication of fluid overload. But above all, as stated by Javier Belda, is that we need to individualize treatment and find this balance between hypo and hypervolemia. So individual care for each patient at each point in time when we are taking him during the different phases of fluid therapy. So passive leg raising, if you turn the first lecture by Professor Monet around, you can use these parameters as well to guide the resuscitation. And they show that if you look at patients with dialysis and who have hypotension or not when you ultrafiltrate fluid, you can see that those who have a positive passive leg raising, and it is with the same threshold around 10%, they will have hypotension during hemodialysis, and maybe they are not so fluid overloaded. So another possible parameter is volumetric preload. If the volume is high, maybe this relates to fluid overload, and you can even improve these volumetric parameters. As Cardiac Art put as my friend, and there are many new devices on the market and friends come with benefits, and I think it's important that we use the benefits and not use just the monitor for cardiac output alone, but also look at global end diastolic volume, look at extravascular lung water, as it gives important information. This is how we do it. We correlate the ejection fraction with the end diastolic volume, trying to identify what would be the good range for each patient. And in the study we show that indeed volumetric preload parameters will decrease when you remove fluid, which is most often not the case if you look at barometric parameters. So what about lung water? I already talked about this. And we found that it's related to capillary leak, to positive fluid balance, and increased intra-abdominal pressure. And if you have a lung water which is high and it drops with your treatment and fluid removal, this is a good predictor for a good outcome. So we identified a non-responder as a patient who has a high lung water and it remains high, and you see that the non-responders have a positive cumulative fluid balance, relates a little bit to the global increased permeability syndrome. So if you achieve late conservative fluid management, you have a better survival and a faster weaning of the ventilator, which is the same if you would be a responder being a patient with a drop of 2 ml per predicted kilo body weight of lung water. So the dynamics and the evolution of the parameters over time are important. As Sherman's group showed, that pulmonary vascular permeability index may be an interesting parameter as well to discriminate between hydrostatic versus hyperpermeability pulmonary edema by dividing the lung water over the pulmonary blood volume. So this parameter will be much higher in hyperpermeability edema. And it has been shown in this study, again by the group of the chairman, that in ARDS this PVPI is much higher. And this could be a good parameter to identify patients with ongoing capillary leak. So I apologize for having included a slide on abdominal pressure, one of my preferred topics, which is in fact that if you have congestion and venous congestion, you will develop second space and third space fluid accumulation within the abdomen, and this will increase intra-abdominal pressure. So we looked at the effects of renal replacement therapy with net ultrafiltration of about 2 liters, and you can see that this may result in a drop in the intra-abdominal pressure, as well as in the global end diastolic volume and the extravascular lung water. So fluid removal has an impact, and these could be interesting parameters. So what about new techniques like bioelectrical impedance analysis? So I would like to present the case of a patient with a high lung water of 16, very poor oxygenation of 98, and a positive cumulative fluid balance. And you can measure this with the bioelectrical impedance analysis, gives you a number of the volume excess. So what did we do? This was the initial status of a patient with polytrauma. So we recruited the lungs, we set the PEEP, we gave some hypertonic albumin and furosemide, and the next day you can see that the chest X-ray got better and the measurement of volume excess decreased. So we had put patient on dialysis, We further removed the fluid, so you see the volume excess coming down, got back to normal. And with these new machines, it also allows you to have a look at the efficiency of your dialysis, the KT/V, and to show the evolution of the extracellular water. And you can see that the patient, from being edematous, went to the normal range by getting rid of the excess fluids. We just preliminarily looked at this in ICU patients and found that ICU patients have a volume excess as compared to healthy individuals, and those patients who are going to die also had a much higher volume excess. And by using this to define fluid overload, because it's the 10% cutoff above baseline weight, you can see that patients with fluid overload defined by bioelectrical impedance analysis had a poor outcome. So just one more thing, and which could be interesting, is the frusemide stress test to identify patients with fluid overload. It has been used by nephrologists to assess tubular function. So you give a slight dose of frusemide and you check the urine output, and why not inventing a ready for de-resuscitation test by just giving a little bit of frusemide and then looking at the slope of the urine output. If you would reach 200 mL within the first 2 hours, this would identify a patient ready for de-resuscitation. So ladies and gentlemen, to wrap things up, I would first like to extend the kind invitation to join us at the Fluid Academy Days in Amsterdam end of November. If you can't wait, join us in Dubai in April.
Okay.
So, I would like you to go home with the following messages. Fluid overload is defined by a cutoff value of 10% increase in body weight. It is associated with increased mortality, length of stay, ventilator days, and it is associated with organ failure, and this is what I refer to as global increased permeability syndrome. It's the absence of transition from ebb to flow phase. So how should we guide resuscitation? Well, I think clinical science, lab science, some may be promising, like the dilutional anemia or the protein levels. Static imaging like chest X-ray is useless. Dynamic ultrasound like inferior vena cava collapsibility index, but with the limitations that I show you in obstructive shock. Use volumetric preload indices. We're going to remove fluids, so monitor the volume and not barometric preload. The absence of fluid responsiveness, if you reverse it, could be an indicator that the patient will be ready for de-resuscitation. So low pulse pressure variation and a negative passive leg raising. Assess the organ function with lung water, with permeability index and abdominal pressure. Avoid hypoperfusion, and there's not much data on that. And some techniques may be promising for the future. I thank you for your attention.